All right, it's 2:01. I'm anticipating a lower, and I'll say hi to everybody. Let's see, let's start my video. Hi, everyone. I'm anticipating a little bit of a lower attendance today, possibly due to a few competing events that are all happening at the same time. I know that was one of the reasons that Dr. Warren can't join today because he was like triple or quadruple booked for this time. But we do record and send these events out to everybody afterwards. So at last count, Jessica was telling me we had like 133 registrations for this call. So hopefully all those folks, even if they aren't on live with us today, will have a chance to review the slides and listen to the recording afterwards. But to be fair, for those of you who are on already's time, why don't we go ahead and get started. Hi, I'm Amy Haddad, Director of Public Policy and Government Affairs for AMCHP. And despite the title slide, which still had September 10th date, this is the September 24th AMCHP COVID Town Hall / policy call. Usual housekeeping rules: if you have any technical difficulties, email Jess Cohen, jcohen@amchp.org, or you can chat the panelists in the chat. And we do ask that if you have a question related to the content today, that you make sure to switch in the chat to all panelists and attendees so that other attendees can also read your question. So for our agenda today, I'll give a quick legislative update. We'll have an MCHB update, CDC COVID update, and then we will cover some really important topics for the time: vision health and teen pregnancy. COVID relief, same as we've been saying for about 2 months now. It does not look like much progress, and we don't expect any anytime soon, which is obviously not what any of us wanted, but the Senate has not, and the House have not been able to come together on a package that would be mutually agreeable. In fact, the Senate hasn't been able to pass its own bill. So we are just really concentrating right now on making sure that legislators still know of the emergency needs that we have, but understanding that it might be more plausible to get things done during the appropriations process. Speaking of which, there is some movement on that. The House did pass a CR, continuing resolution, 2 days ago to keep the government funded through December 11th, and the Senate is expected to pass it within the next week. So we don't expect a government shutdown, but this really pretty much keeps things level funded. It does include some extensions for programs like community health centers, PrEP, and the SRAE, as it's called now, which used to be the abstinence only education program. I think it's a teaching health center. So a couple of programs that are extended, but other than that, it's pretty much a straight continuation of previous year levels through December 11th. I was on a call earlier today where Chairwoman Rosa DeLauro spoke, and it was an off the record call, so I'm not quoting anything there that like she probably hasn't said in the press as well. But, you know, just saying, you know, yes, like they have this CR now till December 11th, but, you know, there could be another CR before they actually continue doing the FY21 appropriations in full. So I think it's really likely that we could see us continuing on last year's levels, you know, well into half of the next fiscal year, which is really, it's not enough when we're in the middle of a health crisis. So we'll keep pushing, but it, you know, with the election coming up and with other priorities now in front of the Senate, it's looking less and less likely to have a COVID bill. So with that, I'm going to turn it over to Laura Kavanaugh, the Deputy Associate Administrator of HRSA's Maternal and Child Health Bureau. And Laura, like I said, just let me know when to advance your slides.
Thank you, Amy. You can go ahead and advance to the next one. Thank you so much. Such a pleasure to be with you this afternoon. I'd like to tell you a little bit about our new Children and Youth with Special Healthcare Needs Summit series. This past Tuesday, the Maternal and Child Health Bureau held a kickoff meeting to this series. And the primary goal of it is to strengthen the system of care for children and youth with special healthcare needs and their families. Prior to the kickoff, the Bureau, with input from the field, developed a draft blueprint that outlines specific goals and objectives in 4 key areas, including health equity, family and child well-being and quality of life, access to supports and services, and financing of services. The goal of this work is to develop actionable goals and objectives at the community, state, and federal levels. In particular, we're interested at potential priorities and opportunities for programs and systems supporting children and youth with special health care needs that will guide our strategic programming for the next 15 years. So this is really a long-term focus for us. At the kickoff earlier this week, we had over 125 providers, researchers, government officials, family and consumer leaders, young adult leaders, and nonprofits in attendance. And while we recognize that not all of our Title V partners were able to attend that meeting, we do plan to host a Title V listening session and provide other opportunities for your input. Next slide, please. We hope that you'll be able to attend the Title V listening session on October the 13th from 3:30 to 4:30 Eastern, hosted by AMCHP. On this slide, you see the overall timeline for this work, where we hope to be completed, have the blueprint completed by the summer of 2021. If you have any questions or comments about this work, please email cyshcn@hrsa.gov. Next slide, please. In a few minutes, you're going to be hearing from Donna Fishman, who is from Prevent Blindness's National Center for Children's Vision and Eye Health. The National Center was established in 2009 with support from the Maternal and Child Health Bureau. And the goal is creating a public health infrastructure that promotes a comprehensive system of vision care and eye health for young children. To date, this program serves as the only federally funded program that supports a public health approach to vision screening in young children ages 0 to 5. Both the U.S. Preventive Services Task Force and the 4th edition of Bright Futures endorse vision screening for all children ages 3 to 5 years. However, results from the 2016 and 17 National Survey of Children's Health found that only 39% of children ages 5 or younger had had their vision tested. The American Academy of Pediatrics strongly encourages the continuation of regular child visits, as you have heard us emphasize in these calls previously, even during the COVID-19 pandemic. And vision screening is a very important part of that well child check. As you are well aware, uncorrected vision can negatively impact development, interfere with learning, and lead to permanent vision loss. And we look forward to hearing more from Donna later in today's webinar. Thank you so much, and I'll turn it back over to Amy now.
Great, thank you so much. There was a question, it was the September 22nd event recorded, Laura?
Yes, it was, and we can share it if you weren't able to attend in person.
Thank you. All right, now we are going to turn it over to Dr. Remley, Director of CDC's National Center on Birth Defects and Developmental Disabilities.
Good afternoon, everyone, and I hope everybody is safe and healthy, and I enjoyed listening to people talk about the challenges of teaching your children and being part of the school from home. I just made me, when you said kids are learning the word frozen and mute, non-mute, it really brings it all home. I want to today defer most of my time to our 2 subject matter experts from the response, who are co-authors on some recent papers that I think will be of great interest to all of you on the call. But before I turn it over, I just want to highlight the importance, as you all know, of getting a flu vaccine, especially for the populations we serve. And I challenge all of you to get out there and get your flu vaccine before the next call we have together. So when we ask who's gotten their flu vaccine, we can all raise our hands. I think, leading by example is always one of those things that's critically important. And it's easy to have it slip your mind as you're going through all the other important challenges you have every day. So with that, I'll be turning it over to Miranda Delahoy and Dee Bixler to talk about the 3 recent papers that have just come out around COVID.
I have Dr. Delahoy first, so.
Hi there. This is Miranda Delahoy. I can actually put my video on for a minute here. Pardon the hotel. So thank you so much for having me today, and thanks for the opportunity to share some of our work. I'll be providing an overview of an analysis of nearly 600 hospitalized pregnant women with laboratory-confirmed COVID-19 identified in the COVIDNet surveillance system. We recently published a report of our findings in CDC's Morbidity and Mortality Weekly Report. I'll present some background on the data source for this analysis and discuss the main conclusions, and then I'm happy to answer any questions. Our report described data collected through the COVID-19 Associated Hospitalization Surveillance Network, or COVIDNet. COVIDNet surveillance was initiated on March 1st of this year, utilizing the infrastructure of two existing respiratory surveillance platforms for influenza and RSV. COVIDNet conducts population-based surveillance for laboratory-confirmed COVID-19 associated hospitalizations in 14 states encompassing 99 counties. The catchment represents all 10 HHS regions and approximately 10% of the US population. To meet the COVIDNet case definition, a person must be a resident of the predefined surveillance catchment area and have a positive molecular test for SARS-CoV-2 during their hospitalization or up to 14 days before admission. Throughout this presentation, I'll refer to persons meeting this definition as having COVID-19 associated hospitalizations or as having COVID-19. SARS-CoV-2 testing in COVIDNet is performed at the discretion of healthcare providers or through facility policies dictating uniform or criteria-based testing of patients upon admission. COVIDNet does not collect data on non-hospitalized persons or on persons who do not test positive for SARS-CoV-2. For each identified case, trained surveillance officers perform medical chart abstractions using a standardized case report form. COVIDNet routinely captures pregnancy information for women aged 15 to 49 years. Pregnancy information was available for approximately 97% of the women in this age group who had completed chart abstractions. The study period for the analysis was March 1st to August 22nd. We included a convenience sample of women aged 15 to 49 who were pregnant at hospital admission and who had completed medical chart abstractions and a discharge disposition at the time of analysis. We did not have complete data for all pregnant women at the time of the analysis, but eventually plan to complete all chart abstractions for pregnant women. Pregnant women described in COVIDNet may have been admitted to the hospital for any reason, including COVID-19 associated illness, obstetric indications such as labor and delivery, or other reasons. We describe clinical characteristics and outcomes of hospitalized pregnant women with COVID-19 and birth outcomes for pregnancies specifically completed during the COVID-19 associated hospitalization. We defined women with one or more symptoms at hospital admission as symptomatic, and this was based on a list of symptoms indicated in COVIDNet. Women without any symptoms we called asymptomatic. Pregnant women accounted for a substantial portion of COVID-19 hospitalizations among women aged 15 to 49 years, with approximately 1 in 4 hospitalized women in this age group with laboratory confirmed COVID-19 being pregnant. Analysis of data from 598 pregnant women found that approximately half of hospitalized pregnant women with COVID-19 had no symptoms at hospital admission. Some pregnant women with COVID-19 who had symptoms experienced severe outcomes, including admission to an intensive care unit for about 16%, invasive mechanical ventilation for about 8%, and 2 deaths. Among all pregnancies completed during the COVID-19 associated hospitalization, 98% resulted in live birth and 2% in pregnancy loss. 2 live-born newborns died during the birth hospitalization. Of pregnant women who gave birth during the COVID-19 associated hospitalization, the proportion of preterm deliveries among live births was approximately 3 times higher among symptomatic women than among those without symptoms. Some limitations, of course, exist. These data are preliminary. Chart abstractions were only completed for about 30% of women aged 15 to 49 years identified in COVIDNet, and that remains ongoing. Maternal and newborn outcomes were limited to those occurring during the COVID-19 associated hospitalization and captured in the maternal medical chart. So some public health implications of our work. First, we still don't know enough about the short and long-term consequences of COVID-19 infections for pregnant women. CDC is collaborating with state and local health departments to conduct detailed surveillance of pregnant women with COVID-19 and their infants. Second, testing policies based on the presence of symptoms might miss COVID-19 infections among pregnant women. So monitoring of pregnant women with COVID-19, including those without symptoms, is important to understand how the virus affects mothers and newborns and to guide prevention strategies. Finally, pregnant women and healthcare providers should be made aware of the potential risks for severe COVID-19 illness, adverse pregnancy outcomes, and ways to prevent infection. So thank you so much for listening and to all of my collaborators on this work, and I'm happy to take any questions.
Thank you. Are you turning it over to Dr. Bixler now, or? I can put up. Great. All right, you got your video on. Go ahead. We can't hear you though.
Try again. There we go. Okay. I wanted to thank you very much for inviting me. Even though this is a topic is a little bit somber, we're going to be talking about pediatric deaths related to SARS-CoV-2 infection. I'm actually really excited to talk about maternal and child health, or talk to a maternal and child health audiences, because y'all are the folks that can help build the health systems that make this kind of thing less likely to happen. So I'm very excited and honored to be here. So let's talk about our study. Our study included pediatric patients defined as under 21 years of age who died between February and July 2020 and met the case definition either for COVID-19 or MIS-C. So 50 states, New York City, District of Columbia, Puerto Rico, Guam, and the Virgin Islands were invited to participate. We had 47 respond, and 20 of those reported no cases, and 27 reported at least one case. So our study time frame was between February and July of 2020. And among persons aged less than 21 years, there were almost, during that time frame, there were almost 400,000 cases of COVID-19 and MIS-C. And we also identified 121 deaths. So to understand the key findings of the study, there are 4 key findings. First is that we identified a racial disparity in that although Hispanic, Black, American Indian, and Alaskan Native persons represent 41% of the U.S. population aged less than 21 years, in our study, these groups accounted for approximately 75% of deaths in persons aged less than 21 years. So that was the first key finding. The second thing that we identified is that deaths were more prevalent in persons aged 10 to 20 years. At about 70% of the deaths occurred in persons 10 to 20 years of age. And young adults aged 18 to 20 actually accounted for 40% of the deaths. So if you look at the paper, there is actually an age distribution that's one of the figures, and you can see sort of a J-shaped curve showing somewhat higher numbers in infants less than 1 year, but really quite an increase in numbers of deaths with age, with, again, 40% of all deaths that were reported were in the 18 to 20 year category. The third important finding is that 75% of decedents had at least one underlying condition. and 45% had 2 or more underlying health conditions. And the most commonly reported medical conditions were chronic lung disease, including asthma, obesity, neurological and developmental conditions, and cardiovascular conditions. So those were the more commonly identified underlying conditions. And then the last finding is that 32% of persons less than 21 years during this time frame actually died at home or in the emergency department prior to hospital admission. So almost a third of these decedents did not make it into the hospital before they succumbed to their illness. So what can we do with this information? And again, this is where I'm grateful to be talking to folks that are doing maternal, child, and family health. First, addressing the racial and first, I think our major message is that persons in the pediatric population, particularly those from racial and ethnic groups disproportionately affected by COVID-19, or those persons with underlying medical conditions and their caregivers, these folks need and deserve clear, consistent, age-appropriate, culturally appropriate messages highlighting the importance of wearing masks, staying at least 6 feet apart, and washing hands frequently to prevent COVID-19. Because of the racial disparity, really also captures our attention as an important issue, because these persons were disproportionately affected. In the paper, I'd encourage you to look at reference 7, which is a web page that the CDC folks that are working on racial equity put together. It is actually a very readable as well as very comprehensive resource on these issues. And that page has a link to another page that is basically entitled What We Can Do. And it lists actions that public health agencies can take, that healthcare delivery systems can take, that employers can take, that faith-based organizations can take. So it's actually a really nice practical resource and would be something that you could share with stakeholders in your community. The other thing that is really important is in terms of the issue or surrounding chronic underlying conditions. At this time, it's really important to encourage parents to continue to keep in touch with their child's health provider, maintain well child visits, including vaccinations, so that children can stay healthy. Or if children have chronic conditions, that they should continue to manage those chronic conditions. We do have some evidence that parents have not been taking children to well child visits and vaccinations, and that definitely poses a concern. And then finally, addressing the issue about adolescents. You're undoubtedly all very familiar with the unique needs of adolescents in the healthcare system. And our paper emphasized that adolescents in particular need patient-centered care that's coordinated, integrated, strengths-based, and sensitive to the unique needs of adolescent patients. So that's all I have, and I wanted to thank you once again for your attention and all the very important work that you do, and I'm happy to take any questions.
Thank you so much. We did have one question in the chat box. Jerry, if you want to unmute yourself, you may do so.
Actually, this is Jerry. Thank you. I actually went to the link, so all the information is there. So thanks.
Oh, great.
I'm good.
Okay. Well, thank you so much, Dr. Bixler. Next, I'm going to turn it over to Donna Fishman with the National Center for Children's Vision and Eye Health that Prevent Blindness.
I'm not unmuted. Okay, now I'm unmuted. Great. So thank you so much. I want to thank Amy, all of AMCHP for this invitation, and to Laura for the introduction and to give a little context for vision health in this country and through MCHB. So really excited to be here. We've been, as Laura said, thank you. We've been funded by HRSA since 2009 at the inception of our center. So I just wanted to first just let you know the couple things I'm going to cover today in a few minutes. One is just who we are as the National Center for Children's Vision and Eye Health, talk about our COVID-19 response, a couple of things that we're doing, and our considerations and frequently asked questions document, and then talk a little bit about our resources. Next slide, please. Great, thank you. So who are we? So the National Center for Children's Vision and Eye Health is part of Prevent Blindness, which is one of the oldest patient advocacy and education organizations in the country. So Prevent Blindness's mission is very simple: to prevent blindness and preserve sight throughout the lifespan. Our mission for the center, we support the development of a public health infrastructure to promote and ensure a comprehensive multi-tiered continuum of eye health and vision care for young children. And we do serve kind of the whole spectrum, 0 to 18, but most of our focus, and certainly in our HRSA work, is young children, as Laura mentioned, 0 to 5, and the unique vision health needs there. All of our work centers around equity and making sure that all Americans, all children, have equal access to eye care. And I will say that we're going to be doing a follow-up webinar October 29th, so I hope you mark your calendars, and we'll be giving a little bit more perspective and show some additional data to what Laura mentioned from the National Survey of Children's Health. We'll talk about children's vision. So next slide, please. So I want to talk a little bit just briefly about what our work is. We are a technical assistance center, and we can serve anybody. We serve states, communities, NGOs, federal, state, local, public health, education agencies, very broadly. Our work is based on science and evidence. Back in 2016, 15 or 16, we published 3 articles in a peer-reviewed journal. One was on vision screening guidelines for children ages 3 to 5. One was on data collection procedures and recommendations, and one was on performance measures. So I encourage you to check out our website and look at those. Most recently, as you can see here, we collect a lot of data, lots of data from the National Survey of Children's Health, the vision questions there, and we've just produced a new version. There was one a few years ago, and now there's one just published this year in July, Children's Vision and Eye Health, a snapshot of national issues. We do provide technical assistance to almost every state in the nation in our last 11 years. And almost every year we serve at least 30 to 40 states or folks locally in different states. We run the only national certification program for vision screening, and we focus a lot of our time on parent and caregiver education and awareness around vision. So one of the other big projects we're doing right now is we're running a community of practice, and I'm really excited that we have 8 teams, and one of them will be featured in our next webinar talking about their work with their state Title V. Next slide, please. So just to show you the multidisciplinary approach that we take to looking at children's vision. Laura had mentioned the important role that well-child visits play, which of course all of you know in preventive health care, and what's happening now with COVID, that many folks are not getting immunizations, many folks are not bringing their kids for their well-child checks, which means they're not getting their health screenings. We do know that not every child who gets a well-child check is actually getting a vision screening. That's some data that we've had, and that's disconcerting. So we really work across multiple multiple disciplines between the federal government, the healthcare sector, the eye care sector, everyone you see here in schools. Vision really sits at the intersection of health and education. And so we work very broadly. Again, we work with, the states and some of the maternal and child health programs. Vision tends to be a little bit siloed. And so our role is to bring together different disciplines, different people, and all of our expert advisors, and say, how can we advance vision? How can we make sure that vision is approached in an evidence-based way in the healthcare sector and the eye care sector, of course, and through the education, early childhood sectors. So just wanted to give you that little bit of background. And now, if you next slide, please. Great. So now we can talk a little bit about how we are ensuring clear vision and eye health during COVID-19. I've given you the website here. So we were getting a lot of questions, of course, on how can I still do a vision screening during COVID? And, I have to get close to a child, and my childcare center is not open right now. What do I do? So we were having a lot of questions, and we thought we really need to develop some considerations. And so we worked for months on this, looking at all the different guidance that was out from the CDC and HRSA and all different organizations to make sure that we are giving the best evidence that we could. So I just want to give a very little bit of background on vision screening, because I'm not sure all your programs provide how you provide screening. Vision screening is part of a comprehensive system of vision and eye health for children, along with professional and family education, referral to eye care when indicated, coordinating care among vision care providers, primary care providers, vision screening programs, and families. So that's how we see vision screening as part of a whole system. About 2/3 of states mandate vision screening in schools, and half the states have some mandate for preschool vision screening, mostly in publicly funded preschools. We also know, of course, through early intervention programs that there's vision assessment and services, and we know that the USPSTF, as Laura mentioned, and Bright Futures also recommends vision screening at certain intervals. And so there's lots of information out there, and yet we know that not enough kids are getting screened. So we're especially concerned during COVID that even fewer are getting screened. So with the pandemic, we are aware that early care and education programs and schools, everyone is adapting their practices around opening, precautions, testing, cleaning, disinfecting. And so we developed our considerations as an adjunct to our evidence-based vision screening guidelines that I mentioned before. We have a whole website, Vision Screening Guidelines by Age, I encourage you to visit. And our key takeaway is kids should still have their vision screened, and they should still be screened using evidence-based practices with some adaptations. And we feel very confident with these considerations that vision screening can still be done and still be done safely. So our documents are not designed to provide any clinical standards or guidelines. I just want to make that really clear. Next slide, please. Great, so I want to talk to you just a little bit about our process for how we develop these considerations. As we do with all of our work, we gathered our stakeholders, both for the development and for the review of these considerations. And so we brought in, to start, school nurses, folks who are really at the front lines, school nurses and our university level professors who work with school nurses and teach school nursing. Head Start, the Office of Head Start and their Technical Assistance Center in Early Childhood Health and Wellness, the CDC School Health Division, eye care providers and associations, including the American Academy of Pediatric Ophthalmology and Strabismus, and a representative from the AAP, and then our expert advisors. And we are comprised, our National Center, of folks who are vision scientists, who work in eye care, also public health, Head Start, and our parents. So we made sure we had broad representation, and the guidelines were drafted by the chair of that work group, who's Dr. Martha Bergring, clerical professor emerita at the University of Illinois College of Nursing. on behalf of the center. And so, as you can see here, we've adapted evidence-based vision screening guidelines during physical distancing, and that's the core of what this work is. What we looked at lots of guidelines from, you can see the organizations here, as well as APOS, the American Academy of Pediatric Ophthalmology and Strabismus, and many states had already come out with some guidance and guidelines. And so we reviewed everything we could. Continually, as you all know, the guidance was often changing. And so what we're going to talk about and what you'll see on our website is the culmination of that. Next slide. Thank you. So here's what our product looks like. The different components include planning and supplies, hand hygiene, cleaning, disinfecting, the use of face coverings, and then obviously getting into the meat of it with vision screening and shared objects that are used with vision screening, and then training for and the safety of vision screeners. And so this is all what's addressed. Some of the material can be used like a checklist to make sure that as you're planning, you are making sure that you're planning your screening session according to evidence-based guidelines and according to safety protocols all the way. So what we've included are considerations for modifying vision and eye health screening procedures during the pandemic, and just want to make sure we're getting the word out that not adhering to evidence-based practices could lead to missing a vision or a high health disorder, not recognizing kids who are at high risk. And then we include a section of parent and caregiver education, which can be applicable to home visitors. And we'll talk a little bit more about that in a minute. I do want to mention, I know that some of you on the call work with the special children and youth with special healthcare needs. And I just want to say this is not part of COVID necessarily, but that we have information on certain conditions where we recommend a direct referral to eye care. So I just want to read those to you just to make sure that we're all on the same page. Children who are at high risk for vision disorders and those with readily recognized eye abnormalities should be referred directly and in a timely manner to an appropriate eye care professional. This includes children with the following: neurodevelopmental disorders, systemic conditions that have associated ocular abnormalities, first-degree relatives with strabismus or amblyopia, a history of prematurity, and of course, parents who believe their child has a vision problem. And so those are the kids that we believe need to go directly to eye care and bypass a vision screening. Next slide, please. Thanks. So I just wanted to highlight a couple of the considerations. Our document's about 6 pages. I'm not going to go through it all, but just want to show you a smattering of what's in there in terms of making sure that the screener and the children who are being screened in a mass screening, everyone is wearing face coverings, that all vision screeners should have training, and all of that training needs to be endorsed by whatever the agency that they work with, and follow all of their protocols for safety, of course. And then I want to focus on a couple that I think are relevant to your programs, those of you on the call today. One is our 18 vision developmental milestones from babies to first birthday. And this is a tool that folks who are home visitors can use to assess babies birth obviously through first birthday, and we have that in English and Spanish. And again, this is a tool. We don't do vision screening. We don't use photo screeners with kids who are under 1 year old. And so I just want to point that we include that in the considerations. And also we have a checklist for parent education that we encourage you, if you are running home visiting programs, to get this information out to your home visitors, to utilize this tool in particular as a resource for parents. And then again, we say, follow all the instructions of vision screening charts and instruments as you would. And then we give some more detailed explanation of how to do those adaptations. Next slide, please. Thanks. So I just wanted to give you a couple ideas of some of the questions that we address in our FAQs. How do we do a vision screening to closer than 6, to when we have to get closer than 6 feet? I have special education students who wear masks. What should I do? And then screeners. So there are sometimes screeners who go to multiple sites, and this can be, and that answer can be relevant to folks who work in homes and are going, again, or just going to multiple sites, multiple health departments, or however you work. And again, some of these are general recommendations are if there's any concern about screening kids having that can't wear a mask, or you can't go to multiple locations, again, we say kids should be making appointments with eye care, and coordinating, of course, with their primary care. So I hope you'll be able to share some of this information with maternal and child health programs, and take a look at all of these resources. Next slide, please. Just want to talk about a couple of things, as well as these considerations and our FAQ. We also have started a newsletter, and we talk about some COVID issues there with the eyes, as well as just other issues for parents. Give a lot of resources. Happy to share any resources that you have. And then, as I mentioned before, this is really kind of a seminal part of our website, and my colleague, Dr. Kay Nottingham Chaplin's on the call today, who developed this, is our vision screening guidelines by age, and the website's right here. So we are excited to be able to offer so many resources to you and hopefully out to the field. Next slide, please. Great. One thing I want to point out as a resource is we are about to launch a new family education toolkit called Small Steps for Big Vision. It will be launching October 20th. I'm giving you the website there. And we'll be recording that if that date doesn't work for you, but it is an eye health information toolkit for parents. We've done extensive focus groups and work with Head Start to learn why is it that some families are not making appointments or keeping appointments and getting kids to eye care, and really looking at what are some of the systemic barriers, and we look at health disparities and why are parents not getting there. And one reason we know is cost. And I want to mention that Prevent Blindness does run we coordinate some voucher programs so that no child or adult should ever go without a vision exam or treatment. And so I encourage you to look at our website for that. So we do have the voucher programs. But parent education was an issue that was brought up a lot by Head Start. They didn't understand that vision is important to healthy development and learning, and that it's very hard to learn to read or recognize letters and numbers, or back when we read the hands on the clock, if kids can't see. And there are many of the vision issues that we talk about. Blindness is preventable, hence Prevent Blindness, that we want to make sure we get early detection, early treatment for all kids. And so by having some of this parent education and helping parents, caregivers, guardians understand the importance, we think that's going to increase our rate of completing referrals and making sure that kids get to eye care and get the treatment that they need. So I wanted to make sure that you all knew about this new resource. Next slide, please. Finally, I just want to put a plug in for our next webinar that we're going to be doing, and I think Amy can talk. Oh, she's got the registration up, so awesome, thank you. So I hope to see you then, and we can delve a little bit more into vision and eye health. Next slide, please. So I want to thank you, and also I want to make sure that we are responsive to your questions and your needs, and so I really encourage you to please contact me with any of your specific questions about vision eye health to make sure that that we can get those answered and get you all the resources that you need. So I want to thank you all for this time, and again, thank you, AMCHP.
That was great. Thank you so much, Donna. What a wealth of resources. One thing I'm wondering is, are you getting a lot of questions, and how you're fielding questions about the effect of all the, telework and distance learning, especially on vision, and, what recommendations there are? I mean, children are spending a crazy number of hours sitting in front of small screens all day.
Right, great question. And yes, we are getting that question a lot, and we have some resources. And I have to say there's, this is kind of a geeky answer. There's mixed research out there in terms of the effect of screens on kids. We know that kids need to spend time outside and away from their devices. And so I absolutely will be talking about that on October 29th, but I'll just throw something out really quickly because I think this is really important for adults and kids, and not only is it kids who are spending a lot of time on devices, but it's all of us as well. I'm sure that we're all sitting here with our laptops and our phones. And I just want to talk about the 20-20-20 rule. Every 20 minutes, look 20 feet away for 20 seconds. And that's really just an easy way to remember to rest your eyes and to give your eyes a break. We do have a fact sheet on our website, and again, I'll share this in a couple of weeks, about myopia, and that myopia has really become a worldwide epidemic. I'm really glad you asked about this. And again, there's research kind of every which way on myopia, but we know that being outside, kids should be outside, and I'm just going to throw out there about at least an hour a day, because that sunlight really actually impacts the shape of the cornea. So really want to just make sure that we are helping kids to take those breaks, and adults as well, all of us. So I just want to encourage it. We always, part of our parent education isn't just how we need to take care of our kids' eyes, but how we need to take care of our own eyes. And that's also part of our small steps. So you will learn a lot about your own vision too. So thanks for the question, Amy.
Wonderful, thanks again. And now I'm gonna switch gears and turn it over to Sarah Luff, who will be sharing with us from California on some trends in teen pregnancy. Sarah.
Hi everyone. Amy, can you hear me okay?
We can.
Great. Hello everyone. Good morning or good afternoon, depending where you all are. So I'm the Title V director in California, and this came up on a call a couple weeks ago. I think, right at the end of the call, I put into the chat box a question about whether anyone was tracking or looking at trends in adolescent pregnancy. And Amy reached out and thought that this could be a good kind of discussion topic for the next call, which I was really excited about because, so in California, as I'm sure, all of you are experiencing, there are so many things happening simultaneously and so many different areas of concern that we're tracking, that it's easy to kind of let adolescent health, it might not always rise to the top because it doesn't always feel quite as urgent, or it just might not come up in our discussions as much. And so, but it did start coming up recently. We've been starting to hear from our local agencies that they are having increases in referrals for adolescent pregnancies. We've been hearing that one of our programs, which supports pregnant and parenting young people, they're having program wait lists in areas that have not ever experienced wait lists before. And, of course, it all makes sense. We had, of course, that time in March and April where people were really not accessing preventive care services hardly at all. And of course that can, at a lower level, that's still continuing. One of our programs has heard that, a lot of those pregnancies may have happened during that period in March and April where there just really wasn't any access to, kind of routine preventive reproductive health care. And, so I think kind of the big picture for us as we're looking at this kind of like two-pronged concern. One is this lack of access for reproductive health care in the ways that our young people would usually access it. They're able to leave school without, without needing to notify a parent to go access contraceptive services. Of course, that's not an option anymore. So there's this access to service piece. And then the other piece that's compounding it is lack of their typical sources of comprehensive sexual health education. So we have, our state level sexual health education programs have seen really dramatic declines of course, because, you know, most of the group settings that they were implementing in, they can no longer be a group setting, or if it's schools, schools have switched to distance learning. And I think, you know, while it's still illegal in California, it's still a legal requirement to have comprehensive sex ed in schools. I think it's, you know, so many things are being figured out right now with distance learning that we may not have necessarily caught up to including that as well. And so, you know, I think it's a lot of kind of different contributing factors that are adding up. We're also hearing that, you know, while telehealth works well, it doesn't work as well for young people who are sharing close quarters with their families, or they may be able to get the prescription through telehealth, but then how do they go pick up the prescription, you know, without having, you know, kind of the same degree of freedom in leaving their home without being monitored, or, you know, they may not feel as safe on public transportation or taking in an Uber. So those are kind of the issues that we're hearing from our local agencies. And while we, of course, haven't been in this pandemic long enough to have adolescent birth data, that is rising to the top as one of our main indicators that we're going to start looking at, you know, kind of around December, January, once we've had enough time that we'll be able to start seeing reflections in the data. And it is something we're very concerned about because we've made a ton of progress on adolescent pregnancy and, you know, and comprehensive sexual health education. And it's something we really don't want to lose, you know, especially in this context where there are so many things that are very high priority, and, you know, we really don't want that to fall to the back burner. So I think that's, you know, most of what I had to share. I'm curious. I'm not sure, Amy, if we have time on the call, but, you know, I'm very curious to hear from other states what they're hearing, if there are any, you know, questions or kind of, you know, areas where we can share information and collaborate on this.
Thanks, Sarah. That was so helpful for putting this issue in context and highlighting things that I certainly wasn't thinking about, like those, you know, how do you leave your house without your parents knowing at this point, right? So not that everyone is, you know, not sharing this information with their parents, but we know many aren't. So yeah, just like Sarah said, I mean, if there are other folks from states who would like to share what they've been thinking, what they've been noticing, or where there might be opportunities to share ideas and brainstorm together. I don't know if our adolescent health lead, Ileana, is on the call today. I don't see her, but yeah, I'd love to hear from anyone. Maybe we have some adolescent health coordinators. Maybe you just want to put in the chat that you're interested in following up on this issue.
Yeah, I mean, I will add, you know, we're, of course, at the very beginning of figuring out how to address this, but we have started talking about, you know, for like, can case managers and public health nurses, for example, if a young person is able to get a prescription through telehealth, can the case manager or public health nurse like deliver it to them, and kind of figuring out the legality and logistics around that. And we know there's been some expanded like scope of practice for pharmacists lately. And so we've also been, you know, just kind of at the very beginning of looking at that, but just trying to really think, how can we, you know, get our levels of access kind of as close to where they were before the pandemic as we possibly can.
You know, I'm thinking about also our conversations around flu vaccine right now, and it's almost like a perfect time to remind young people, like, oh, like this might be your chance to, like, you know, be with a health provider and be able to have that conversation and not have to, like, necessarily, like you said, explain to your parents where you're going or why. Jessica has shared that you've been talking about this on state adolescent health coordinator calls. That's great to hear. Jessica, do you have anything to share? What state are you from? Oregon. Awesome. And now I'm putting you on the spot to share with what kinds of things you've discussed on those calls.
Okay, can you all hear me?
We can, thank you.
Great. It was actually Meryl from California who was on a call with them. Myself, a partner from Nevada and partner from Alaska. And it was really just around, we don't, have the data yet to show us. Frankly, we haven't had a chance to look at the data to show, what level of concern we're talking about. But this is definitely something we were thinking about, definitely back in the spring. We have a lot of school-based health centers in Oregon, and about half of them do offer reproductive health services on site. They sort of abruptly ended services in the spring. And now that we're back in the fall, we're really looking at, how do reproductive health services for young people really work in the time of COVID. And I appreciate all the additional considerations, about it's harder for a youth to be autonomous in their own healthcare for any reason right now. And knowing the sensitivities around reproductive health, we always try and encourage youth to be in touch with their parents and talk to their parents about their reproductive health needs, but we also know the reality that that's not always a great option for youth. So just like that, thinking about if it's harder for youth to leave without being questioned and getting asked questions. So just appreciate the conversation, and I do think it's something that we're all looking at as sort of an additional effect of COVID and the necessary quarantining around it.
Great, thanks so much again for letting me tell you to share with us today. All right, well, it's just about 3 o'clock. So I want to thank, we've had so many wonderful and new presenters today. So thank you to all of you for taking your time and sharing with us, and especially, excuse me, what I know has been a very busy week. As usual, I wanted to remind you again about a webinar on ACA open enrollment season happening on October 7th. Again, you'll all get copies of the slides after the call. Excuse me. And our next call will be on October 8th, so make sure to register for that. And in the meantime, if there are any topics you would like to see covered on one of our upcoming webinars, please, feel free to contact me directly or any member of the AMCHP team, really. And just thank you for all you do. Have a great rest of your day.
Thank you. Bye-bye.